Morning, good afternoon, and good evening from Clinic in Park Hospital in Zurich, Switzerland. Thanks for your patience. We solved some small technical issues. My name is Luigi Sisto, responsible for EP biotronic activities in Switzerland. I would like to give you a warm welcome to all of you attending the first EP Talk session. In these EP Talk sessions, we invite leading experts in the field of electrophysiology to share their best practices and insights, and today it's my distinct honor to welcome Dr. Christoph Scharf. Dr. Scharf will share his clinical perspective on the differences between non-contact versus contact mapping and how that may influence or affect procedural outcome. We very much welcome your questions and kindly ask you to put them in the chat function, and we will address them after the talk. Without further delays, my pleasure to hand over to Dr. Scharf for the presentation. Dr. Scharf, please go on.
Thank you very much, Luigi. I'm sorry for the delay as well. There was some technical problem with the transmission, but let's start and go over this very basic subject, the difference between contact and non-contact mapping. That is something which I know since 20 years, since I'm doing clinical EP in Zurich. And my conflict of interest is that I was a founder of Acutus Medical, which arose from the problems from contact mapping. So when we go over the different mapping systems, the oldest mapping system, the surface ECG, is a non-contact mapping system. It's about 130 years old, as you can see on the right. You can see that the ECG can be recorded from the hands and the feet. You can see a nice P wave or delta wave or whatever little detail from the cardiac electrical activation, because the electrical field is transmitted within the body with light speed everywhere. Then there were newer non-contact mapping systems from the body surface. There was one non-contact mapping system, the N-side balloon, which probably a lot of you know. It had a lot of problems and didn't really gain market acceptance. And then there is AccuMap, and in the future maybe MRI will also be a non-contact mapping system. We will see. On the other hand, the contact mapping systems, they are since 1948 the conventional electrophysiologic study, and then 3D mapping systems, which add up the information that you get with the catheter in the heart. Now, whenever you do 3D contact mapping, you have to keep in mind that you have a sequential mapping. So beat by beat, sequentially, you add up the information, and therefore you need an annotation with a reference. Whereas in non-contact mapping, you do not need an annotation. This is a basic difference, and that you have to keep in mind, because annotation with a reference is subject to error and thereby operator dependent or algorithm dependent. Non-contact mapping without annotation is less operator dependent. That is a big, big difference, and we're going into detail on this. As you see here, a atrial flutter and the coronary sinus electrogram, and you see it's perfectly regular. So you can do contact mapping, you can do serial measurements and add them up to a map. But how do you annotate the proximal CS on which one of these two potentials? Is it version A because CS 1, 2, 3, 4, 5, 6 have one direction, so it would be version A? Or is it version B? We don't know. And it depends on the personal judgment of the guy sitting on the computer, what kind of map you get. This is a case which has also changing activation sequences in the coronary sinus, a Carto case. You see sometimes it's from CS1 to CS9, sometimes it's more banana-shaped, like in the middle. And in this case, we were able to find it with Carto just because we annotated only the beats which were from CS1 to CS9, only the eccentric beats, and we did not annotate the banana beats. And then we found the focus sitting at 12 o'clock on the mitral annulus, going either one way or the other way around the valve and giving this changing CS activation sequence. But what you also can see is that the cycle length is not always the same, so contact mapping is getting here at its limits. Even if you have multipolar catheters with narrow spacing and get a lot of points, just by adding up these measurements and by having unstable conduction velocity and cycle length, contact mapping gets at its limits. You can only map easy arrhythmias which are regular, which have a stable reference, which have a constant conduction velocity mostly, and a constant activation sequence. So that would be one focus. But if you have two foci in the atrium firing at the same moment at different rates, it's going to be very difficult or impossible with contact mapping. And that is our problem. We have mostly irregular arrhythmias, like you see on the left side. No stable reference. We are very happy when these convert to a regular arrhythmia, like on the right side, because those we can map. But the ones on the left side, we need to map as well. We need to find out where they are coming from. And maybe it's a common source on the left side and on the right side. We will go back to that. But first, let me go a little bit into the basics of the contact electrogram. The contact electrogram is obtained by a unipole derivation to a reference electrode. You see here an example of a WPW case. And you see the ablation unipolar here where my mouse is pointing. And I choose this example because it shows nicely what the near field signal is, the Kent spike here. And then you see the big QS, that's the ventricular activation from the entire ventricle, so the far field. You can guess that the local signal is maybe 5% of the whole area under the curve or even less. And more than 95% is the far field signal. Now in our EP mapping systems, we mostly work with bipolar electrograms, especially during flutter and so on. So we subtract two unipolar electrograms from each another. That gives us the signal above, ablation distal signal. Now you see, we only have the timing from the Kent spike here, -23. But we don't know if this is an atrial signal or a ventricular signal. We don't know if the ventricular signal is negative, indicating the site of origin of ventricular activation. We don't know if there is a Kent spike or not. We lose a lot of very, very important information by this subtraction. The subtraction of two unipolar signals is a very, very basic mathematical or engineering operation, and it loses a lot of information. In this case, for instance, the Kent spike was positive endocardially, and we had to go epicardial to get the negative Kent spike and to get a successful ablation in this WPW patient with multiple previous ablation attempts. So if you look at the unipolar electrogram, that can direct you whether you should go epicardial or not. The information of morphology is critical. Now, there have come up a lot of electrodes which have narrow spacing, smaller electrodes, and a lot of companies try to improve it. I just have summed up from an EP system here our signals. Ablation catheter, electrode 1, 2 is the distal tip. And you see the two unipolar electrograms here on the right, and then you see ablation distal below the bipolar electrogram. That's what we get in our EP system. Now, if we make these electrodes smaller and the spacing more narrower, we will subtract more because we have more overlaying signals. And then maybe we have a more localized information, but the principle is still the same. It's a simple subtraction, one signal from the other. Since 1977, we know that the bipolar signal is dependent on direction. If the activation comes sequentially to both poles, you get a very big spike. If it goes simultaneously to both poles, you get the flat line. And anything in between will give you any morphology of the signal, whatever you want. So that's a reason why multipolar catheters are used for bipolar mapping, like Pentaray or the grid. However, still, if you look at the dependence of the bipolar voltage on the conduction velocity, you will find contradictory findings. If you have a very, very fast activation, you will have similar electrograms, one over the other, and when you subtract them, your peak-to-peak voltage will be lower than when you have a slower activation and your two unipoles are more apart. This is not consistent with physiology, that the voltage should increase when the conduction velocity goes down. So you have to keep in mind that even with the best electrode and algorithm, the bipolar contact electrogram is full of error. This is a recent publication from Heart Rhythm on the morphology of the bipolar electrogram in black, depending on the angle of activation. And it's the same signal, but you see, depending on the angle, the bipole looks totally different. So don't go on the amplitude or on the morphology of bipolar electrograms. I know there is plenty of literature of bipolar voltage maps, and this is just because we don't have anything else for routine use in most EP labs. But it doesn't mean that bipolar voltage map is a reliable quantity, a reliable characterization of the substrate of the heart, of the electrical energy of the cells. The bipolar signal can be anything, as you can see here. Here I have an animation. On the right, you see the bipole going one pole, then over the second pole. And because these, if they are activated like a sequential activation, this would be a derivation. This would be a filtering effect of the signal. And when you look at this, this is an example from Atul Verma on a lasso recording. and it was a case where we had the focus firing from pulmonary vein ostium, and the lasso didn't show any signal at all, as you can see on the bottom. And still we were successful with ablation there. Why? If you look at the unipolar raw signal on the top, you see there are big fibrillation waves and then the QRS complex. The cycle length is about 200 milliseconds. And then when you filter it at 30 hertz, already you lose a lot of information. And when you do the subtraction to get the bipolar signal, you have a flat line. So the cooking of the signal in your EP system can produce a flat line of a good raw signal, I would say. Another thing to consider, is a contact electrogram really a contact electrogram? Is it really in wall contact? You know that the patients are breathing, that you have a systolic movement, and the mean shift of these two is about 4 to 6 millimeters. Now, even though you turn on respiration compensation on your mapping system, that doesn't mean that the catheter is always in wall contact. With pressure sensing, you can see how much effect this has. And in reality, mapping catheters probably have around 50% wall contact, and 50% is non-contact mapping with a very poor technology. Also, you have to keep in mind what is the anatomy. If you do anatomy with a contact catheter like Carto on the left side, you will only get where the catheter goes. You will have interpolation between the points to create a shell, and you will miss points where the catheter does not go. In contrast, when you do a non-contact anatomy, for instance with ultrasound, you can see perfectly nice a ridge here between the appendage and the left-sided veins here, for instance, without any interpolation, what you have to delete or so. And you are more confident that you get all the regions of the heart chamber, even when the catheter does not want to go there. So contact mapping is also about contact geometry or non-contact anatomy. I would say also a CT scan is a non-contact anatomy of the heart. Now let's go to the non-contact mapping system, the N-side balloon. That was working with voltage signals and contact anatomy. As you can see on the lower right, the atrium looks quite terrible. It's difficult to see what is what in this atrium. And the correlation to the contact signals was not good. It was 0.53, the correlation coefficient. And that is the main reason that it didn't get widespread application. Now, the reason was the technology, not necessarily the principle. You can get non-contact mapping with excellent correlation to contact signals here recorded on a lasso catheter if you process the signals in the right way, if you look at the right thing. So here you have a multi-electrode non-contact mapping catheter. It's the AccuMap catheter. And what we get with this catheter has a correlation coefficient 0.9, 0.98, 0.97, 0.89879448. That's something else than 0.5, what you saw before. Also, the correlation to multi-electrodes like the HD grid is good. You see 0.9, 0.79, and the time difference of a couple milliseconds is better than the human eye. Now, how do we get these excellent results with non-contact mapping? The reason is that in the past, most people were working with a current model of cardiac electrical activation. This model was assuming currents which flow through the cardiac torso and produce the potential. And as the currents produced the potential, Ohm's law was used, and that was getting misleading information because that's only for really conduction currents. Now, I discussed this a lot with my father, and he's a theoretical physicist, and he said, no, there are no currents in a cell. It's just the charge, which is depolarizing and repolarizing, minimal currents across the membrane. And you have to do a capacitive model, a charge model, and you have to use different equations from what has been used. And if you do that, you get the electrical charge in the heart. Now, to illustrate this, I want to take you a couple minutes into a thought experiment that is really important because, you know, we're working decades with electrograms, with voltage, with potentials. And if we want to go beyond that, we really have to lay back and think a moment about the physics. Imagine you are an astronomer and you know how an optical lens is working, and you use mathematics and inverse process your information. You can get a lot more resolution from the same signal. You can find out where is a galaxy and not a star and things like that. That is well known. Everybody knows that. Now imagine the gravitational field. We can measure the gravitational field strength, and we can obtain equipotential field lines around the Earth or for the Moon or the Sun. Imagine that we would subtract pairs of these equipotential field lines to work with, and that we would work with bipolar gravity potentials. Can you imagine that? That would be very, very complex and very unlogical. And then we would analyze the size of these bipolar gravity potentials and create maps of that. That's not what everybody does. We just take Newton's law, we know how much is the mass of the Earth and the Moon, and then we can calculate the gravity field everywhere in space. And the same is true for the electrical field. We can calculate the electrical field if we know the charge. We can calculate it everywhere. So we measure a potential, but we should then go back to the charge to know the electrical field at any point in the body. That is the real basic strategy to look at the cardiac electrical activation. This is another visualization. You see the cells, the cell membrane with plus and minus charges. They create an electrical field. These are equipotential lines of the field. It's getting weaker, far field here, and getting stronger near the charge. If you look from a 90-degree angle to these field lines, you will see that the positive and the negative envelope is the electrogram that we record. So the difference between the charge and the electrogram has been clear, and this was the principle where we founded the acutus from. So it's a rather complex formula, but it tells you that at any point in the heart, here in this white point, the voltage that is measured here or calculated here on this heart wall surface is a sum of the local charge, of the local electrical charge in Coulomb, and the sum of the distant charges, the distant sources of the potential, the distant coulombs. I hope that makes sense to everybody, although it looks very complex. Voltage at any point is composed by the local charge and the sum of the distant charges, the far field. And if we subtract this from the voltage, we get the local charge. We get the very small depolarized area, we get the curve which is narrow and faster back to the baseline. Now, of course, we can only do that if we have the information of the entire heart chamber simultaneously. This is not something for sequential mapping because it changes every millisecond. It can only be done simultaneously with non-contact mapping of the entire heart chamber. Now, that has been a lot of theory. Let's go into one clinical example. I showed you that example before, a patient with persistent atrial fibrillation. He was treated 4 years ago, so I know his result, and it's really stable. The patient always required cardioversion, electrical cardioversion to restore sinus rhythm. He never converted spontaneously. And you see here the lasso signals disappeared during PV isolation, but the fibrillation continued after PV isolation. This is the clinical problem that we often face in our practice. You see here the fibrillation maps, non-contact maps of this left atrium. You see there is a lot of slowing and heterogeneity here posterior in the middle. This is the first software version 4 years ago. So it's not what we have today, but already here you can see that 3 points indicate a zone of slow conduction where we did our radio frequency ablation. And during that ablation, we organized the fibrillation into a flutter with a cycle length of 240 milliseconds. That's the slide you saw before. And what you see as well is that this flutter rotates around the same area. So fibrillation and flutter came from the same area. You see some artifacts during the QRS complex because of the software, but the basic activation is very clear around the same area as the fibrillation, and with further ablation in this area, the patient converted to sinus rhythm and stayed 4 years in sinus rhythm. So the charge mapping of the atrium with non-contact works quite well. And why does it work so well? My explanation is that the cardiac fibers have a constant orientation. They don't change their orientation in a patient. So there are preferential pathways of activation, and then there are certain areas, like here, this disarray when the fibers split apart, which can create arrhythmias in an individual patient. And with our non-contact mapping system, we can get also the direction of conduction and conduction velocities and get an idea of the orientation of the cardiac activation in the individual patient. So in conclusion, you have contact mapping. So you have the information only on the catheter position. Contact mapping does not give you any information on other points where the catheter is not positioned. Whereas in non-contact mapping, you have the entire heart chamber, which is mapped simultaneously. So sequential mapping and simultaneous mapping, of course, is not for the same arrhythmia. You can do sequential mapping only in regular arrhythmias or in single foci. If you have multiple foci or irregular rhythms, then you really need simultaneous mapping. You have the far field problem of the electrical field of the voltage with both, of course, if you look at voltage. But if you have non-contact mapping, you can go one step further and derive the cardiac charge, the Coulomb, at the heart wall in non-contact mapping, and thereby you can overcome the far field problem better. Thank you very much for your attention.
Thank you, Dr. Scharf, for this enlightening presentation. It was really interesting to see a bit of theory, but also, this practical example at the end. I have a couple of questions from the audience in the chat that I would love to hear the answer from you. And the first one is from basically your nice description of unipolar versus bipolar. In your experience, what would be the percentage of missing the correct spot using only sequential mapping? So we saw that that you said that we lose a lot of information, but how often that will be relevant in the clinical practice?
We see that in patients with multifocal atrial tachycardia, their sequential mapping can be very problematic. We see that in irregular arrhythmias, irregular VT, irregular atrial arrhythmias. We see that with PVCs, where we have only one beat to map. So if we have one beat with non-contact mapping, we can immediately localize it. If we have one beat with contact mapping, we need a lot of time to localize the origin. We see that after electrical cardioversion, when we see immediate recurrence of atrial fibrillation, with non-contact mapping, we can immediately localize, oh, here it came from. But with contact mapping, it's basically impossible to determine where immediate recurrence of atrial fibrillation is coming from.
Okay, thanks for your answer. And also connected to your last point on the atrial fibrillation, there is another question regarding, probably looking at the case you presented. In your experience, your clinical practice, how many patients do you see using your way of ablating persistent patients? How many of them convert to AT or then later to sinus rhythm during ablation? And a bit more details on the mechanism of these organizations and why that happens.
Yeah, that's a usual question. At the beginning, we were ablating a lot, and we wanted to convert every patient to sinus rhythm because we were feeling very happy. So we saw 50% or even more. And there is one colleague in London, Tom Wong, who has 80 or 90% conversion rates. Now, this requires extensive ablation, and we have recognized that some of these patients afterwards come back with flutters and other things. And so patients where we were very happy that they converted to sinus rhythm and so on came back with flutters. And on the other hand, other patients which we cardioverted were doing just fine. So right now, our primary goal is not anymore conversion to sinus rhythm. Our primary goal is to eliminate the most important triggers and sources of arrhythmia. And if we have done that with 3 to 5 active regions, then the patients are mostly doing well. This is also in line with results from the STAR-AF trial that the conversion to sinus rhythm did not predict clinical success, and also in other studies.
Okay, thanks for your answer. Another question is, especially related to non-contact mapping, the global mapping of the chamber. If you see differences in patients that are already ablated or not, or basically patient de novo. So do you see any difference in the performance in non-contact mapping if there are already ablations in place?
Yes, of course, because the previous ablation has altered the substrate. So these patients have not so active veins anymore, maybe just a few reconnections, and mostly have extrapulmonary triggers. Okay. And in my clinical practice right now, I do a pulmonary vein isolation as the first line procedure. And then when they are coming back with arrhythmia despite PV isolation, I do the procedure with the acutus system. But when I have a patient with persistent AF and I can feel that he's probably having extrapulmonary triggers, like this patient, never converting spontaneously, always needs a cardioversion, then we start at first line with the AcuMap system, with the acutus.
Thanks a lot. You also answered my following question regarding the differential ablation strategy. I would say probably the last question that is more like on the technical side from the audience. What is the difference between voltage mapping and charge density mapping? A bit more words on. You already gave like a bit of an explanation. Maybe a bit more word on that would be appreciated.
Yeah, the voltage mapping, as you have seen from the signals, can give rise to error. And therefore, it's very important that you try to eliminate the possibility of error during your mapping. And you can eliminate that when you look at the electrical charge. You can eliminate that when you do sequential maps, a lot of different maps, and see if you have stable results. So for instance, in atrial fibrillation, we do a map initially when we start the case, and then we do a map after PV isolation, and then we do a map maybe 15 minutes later, and then we compare them and see if they have the same extrapulmonary triggers. And surprisingly, a lot of these triggers are the same in the patients. So when they are really the same, then we are confident that we are looking for the right spot. If it's only popping up once, you must keep in mind that it might be also just a coincidence or even a technical thing or something. The mapping of the electrical charge with non-contact mapping is even as precise as the contact mapping with the catheter at the spot. We have simulations done with that, and we have clinical cases which have shown that. So you get the same resolution with non-contact mapping than with contact mapping if you do that carefully. And also the mapping mode, SuperMap, which is more a sequential mode, is a non-contact mode. So it is getting the same resolution, and that is the real advantage, because previously non-contact mapping was much worse in resolution compared to contact mapping.
Okay. The really last question is regarding more your experience with the AcuMap catheter. Basically, it's two questions in one. One is, do you see that as a MAFT or as an advantage for persistent AF? And connected to that, do you treat more patients than before, since we are using the AcuMap catheter system, the acutus system, because you have more treatment options or not?
Yes. I mean, if you look here in Zurich, in Switzerland, around Zurich in 100 kilometers, we have about 25 EP labs. So everybody is doing ablations, everybody is doing PV isolations, and we get a lot of referrals from other clinics with patients which have failed previous ablations. And, you know, even if you have a success rate of 80% in your AFib cases, 20% still have atrial fibrillation. And a lot of these patients are frustrated because they underwent the procedure without any benefit, and they really want to have sinus rhythm. And maybe after a second procedure, the will to have sinus rhythm is even stronger. So we have a lot of patients with chronic atrial fibrillation, even permanent atrial fibrillation, a large atrium, which we would never treat without acutus. So our range of patients which we can treat has expanded substantially. Yeah.
Okay. I would like to really thank you for your time explaining the differences between non-contact mapping versus contact mapping, and also for sharing your clinical experience to the audience, and also to the audience to have dedicated this time to learn more on I will say the frontier of atrial fibrillation ablation, to have a tailored approach for this type of patients. Thanks a lot.
Thank you very much, Luigi. One final word from my side. If I look back to the EP, in the past, we were ablating flutter with different energy and thinking, oh, which energy is the best. Once we determined what are the criteria for complete block in a flutter ablation, we didn't have that problem anymore. If we do accessory pathway ablation, we don't need a contact force catheter or special energy or so. We know how to map it, and when we are successfully mapping it, we have very high success rates. And so my personal opinion in atrial fibrillation is that the energy is not so important, whatever you use to do your ablation, but when you know where to burn, when you can map it, then you will have good success.
Perfect. Thanks again.